I will just continue in the spirit of publicly funded university academic centers of longevity medicine, and we'll give a brief introduction of some of the aspects that my colleagues Tipi and Andrea didn't mention in depth. And once again, thank you so much for being here. I would like to focus this talk specifically on the point of permeating the longevity medicine into the public sector, into other disciplines. So, as most of you know, I'm actually an internal medicine physician. I'm still in the university clinic setting, working on the ward, also in oncology. So pretty much at the end of the spectrum right now, actually in the pancreatic cancer department primarily, which, as most of you know, has a very poor prognosis. And I will be speaking about it tomorrow morning a bit more. But I would like to introduce a few aspects, just to briefly mention them, on how longevity medicine is already being applied in some of the departments of oncology, some of the departments of cardiology, and also mention biomarkers of brain longevity at the end. And of course, longevity physicians' education. So as Andrea mentioned, we need not only to have a quality control and a proper training certification so that we can name ourselves longevity physicians at some point of time, we also need to start to educate right now, permeate longevity medicine into the medical curricula, but also into advanced training, CME, credit, training, etc. So as always, I'm opening with this slide until it changes. I think longevity medicine is such a discipline of such a multitude of other intersections, but it is also a huge part of speed. So it takes from biotech, it takes from AI, it takes from computational science, and those are developing just so rapidly fast that for a clinician in the clinic, it's extremely hard to catch up. We as physicians, all of those here who are MDs, and I know that there is a lot of us, we constantly have to keep up with the novelties that are coming into our fields and our disciplines. So on top of that, to keep pace with longevity medicine is quite a challenge. And at the same time, for those who are already working with healthy longevity patients, I call them patients, you know that they are very well educated, or they are trying to be educated, and they kind of push us in order to answer questions where they want to have credible answers, evidence-based answers, or at least some sort of perspective, how long it might still take to get into what we would say is a valid, credible guideline, maybe recommendation, then guideline, and then quality control. And we will be talking about that in the last part of this day at the HLMS session. And as we heard before, the development of the definition of longevity medicine, now healthy longevity medicine, has had a trace, right? It developed from what we tried to define as AI-based precision medicine driven by biomarkers of aging, moving to healthy longevity medicine society with optimizing health span along the lifespan, targeting age-related processes. And you will have the chance, or you have already the chance, to meet the entire council of the HLMS, by the way, here in person. And they will also be presented at the panel discussing the clinical cases. And as we mentioned, the network, which, if I may say, is growing already. There are people reaching out from different countries that are trying to implement longevity into the public healthcare, into the public settings. However, it is really also very much dependent on the structure of the medical studies and on the medical system in those countries, reaching from the Baltics towards Asia-Pacific. But I think in longevity medicine, we are still quite flexible and, if I might say, also extremely inclusive. And it's really a global movement. So we've heard a lot about the roadmap of healthy longevity. I hope you have all seen the healthcare report about that. This is just an example of the Philippines, what they are trying to do. Similar developments are being seen in Indonesia. So countries that might not be on the radar of all of us, they are also developing towards this direction. So longevity medicine is really a global movement. As you can see, there are many people trying also to implement the biomarkers into platforms, and I think it's beautiful, and I think it's great that those integrations are taking place with the nuances of their specific countries. It's an ongoing learning, and as physicians, we are trying to implement, at this point of time, the so-called tertiary digital layer. That's a frame that I stole from Elon Musk. Thank you. And I think everybody right now, every patient has some sort of tertiary digital layer, being an email, being it hopefully also a monitoring session. And those of you who know me know that I very much embrace AI as a partner in the clinics. And I had the chance to develop some of those implementations into the clinics, both in Switzerland and in China. China is a country that is developing extremely fast. And we see there that the digital extension of the humans is actually coming into the benefit to optimize processes, not to replace the humans. So for example, in China, we have now over 400 internet hospitals, 0 human hospitals. Just like Alex showed us the 0 human lab, that's something that is also very important as an addition to the high-touch approach in the clinic. And generative AI is not only ChatGPT, that's also something that we are using every day, actually, for those who are using biological aging clocks. Some of them, of course, where we are trying to use a lot of data from really the minimal parts of from omics, multi-omics, through other multi-dimensional data, very granular. So from imaging and functional testing, so ECGs and the bone densities, imaging, right, including brain, blood tests, of course, and other biomarkers. And all this in order for us to really change the paradigm of how we are guiding the patient through the health span. If there is an extension of a lifespan, that's, I guess, for most of the people, a very nice side effect, but the health span is something that we are extremely passionate about. And we want to make sure that this part of the peak optimal performance and the pace of the decline, especially the functional decline, both physically and mentally, will be decreased. And that we will have the tools, both on interventions and also on diagnostics, to always restore the biological age of the optimal performance for a specific individual at a specific point of time. And this is something that exactly longevity medicine is trying to do. So being guided rather by biological age, with all the problems that we heard about and we know of, we still are in the phase of getting the biomarkers, getting the clocks that will actually be applicable in the clinic and guiding us and giving the right education to the patients of what that biological age actually means. But still, I think at this point of time, it's very important to at least try to shift this paradigm. And I hope that at the end of this presentation, I will show you why we see that it's already quite useful in the so-called sick care. Of course, there is caution to be always there on the minds of physicians, caution with AI. I recommend this article in Nature Medicine that is very nicely illustrating what are the benefits and what is the mechanism of generative AI and how it can be helpful for medicine, but where also a physician and a patient, especially, who is trying to diagnose with ChatGPT, should be cautious. So where are we now? We still have, of course, the reactive medicine, and that's the sick care that I think is something that will always be there and is very important. I personally think that from the sick care, we learn so much, especially of the needs of the patients, that we can translate to longevity medicine. Prevention and preventatory, primary, secondary, tertiary arm of medicine are extremely important. They are detecting the early disease or the early recurrence. We have good task force and we have good methods there. But what we are implementing with longevity medicine is the way of how we prevent the risks of diseases. How are we able to mitigate them and hopefully at some point of time also eliminate them? And with that, we are also pursuing a higher goal for the public health of as you often hear, closing the gap between the lifespan and the health span, which basically means we are just trying to bring more people from the area of the lifespan, living with diseases longer, to living healthy without that many or non-diseases longer. So closing the gap between health span and lifespan, decreasing the age-related comorbidities towards the decline part of our lives. There are two pillars of longevity medicine. That's something that I'm also mentioning often, and there's always something new that is coming on top of that. I think every year there is a magnitude of new diagnostic tools that are coming out. Biological aging clocks are some of them, but also many others. And we still, of course, very much put our foot on the functional testings that have been validated. What is very useful, of course, is the imaging, so radiological imaging and others. But what we have now more on top of that is, of course, besides of the genetic point mutations towards diseases, so disease-focused genetics, genomics, and the whole omics, I think it's important to mention the polymorphic risk score, where we are trying to assess the risk of a specific patient to at some point of time develop a disease that is actually in the framework of the global burden of disease, so the CVDs and dementias and so on. And pharmacogenomics, that turns to be right now quite approachable in the clinic and quite useful so that we don't treat patients without effect. Magnitude of monitors and trackers are now on the market, and digital platforms are trying to integrate them, which I think is brilliant because it really gives you the instant and the constant monitoring of the patient. And some of them are very disciplined, some of them struggle because of different reasons. But I would like to point out something that is being more and more often used by the patients themselves, because it's available right now on the market in some countries without prescription of the doctors. These are the liquid biopsies in the urine, in the blood, in different tissues at the moment. And that's just one example of many that I have of longevity patients who just took a test somewhere right on the CTC, so circulating tumor cells, and also genetic testing. And there are, unfortunately, sometimes those types of reports that come without any explanation, or the explanation is generic, telling the patient that they might have cancer. So luckily, those patients have somebody to turn to, but very often they don't. So with this patient, we did a further testing with another partner, with a more credible partner, to really confirm in the DNA testing that there is no liver cancer, at least present right now, and of course imaging and so on. But there must be a caution, and I think not to say that patients should not do it or we should not use it. It's just that we as physicians, we should pretty much get into education and help our patients to explain those findings, and also to give them a good longevity protocol. So maybe not to have them test their CTCs every month, and trust me, some of them do that. So maybe it would be more reasonable to do it once a year, and so on. So the granularity in longevity protocol is important, and also, of course, the guidance of supplements. We will hear about them later on senolytics and also on supplements, where I think one of the most important parts is to avoid maybe interactions and mutual destabilization of the supplements, so that we don't work no antagonic effect. Right, so aging is not consistent. It varies in different systems and different organs, and also on the cellular level, we know that. Why is that important to always reiterate? Because of the measurements. So we want to have, of course, optimally at some point of time, the way of measure the biological pace of aging of our patients at the different levels of their organism, not excluding the epigenetics or the influences from around the patient that influences them, and also to measure the speed of the decline of specific functions. And that is partially, extremely partially, and very indirectly already possible with monitors and panels, heart rate variability and on others, but we are still here, I guess, at the beginning. optimally, very often we have the question, which of the biological clocks is the best? At least 2 years ago, that was number one question. Now it's more like which of the epigenetic clocks is the best, which of the other clocks is the best. We are still evolving and we are still learning, but from the clinical perspective, it would be extremely valuable to really have organ-based biological aging clocks that can specifically tell us the pace of aging of a specific organ, so we can target it with intervention and help the patient to keep up the general biological age with the focus on the subgroups. So of course we have a lot of biological clocks already now. What do we use in the clinic? Different clinics use different clocks. What we are usually using in China are the deep aging clocks, and there are different variations. This is just one example of deep longevity, but I think what is important is to say that some of those clocks do not require direct sample of a patient. So the blood aging clocks, for example, require just the results of the blood test of specific parameters, which makes everything a bit easier. And some of them can be outsourced, such as the patient could take photo aging clock by him or herself. But also we have epigenetic clocks, now coming the microbiome aging clock, behavioral aging clock, subjective age, psychological age, those points that are very important, and I will talk about brain age just in a moment. So that's just an example of how we would, for example, follow up a patient's biological age along the lifespan, along the years, and see if the patient is actually increasing or decreasing in the biological age, well knowing that there is a bias and that there are events of life that can modify it. And this is why it's important to have a longevity physician and healthcare professionals to guide the patient, to avoid misinterpretation of those markers. And that's also just one of the examples of the patients who remained at the biological age despite increase of the chronological age. And I think that's already a success. We do not always seek reversal of -20. For some aging clocks, that's actually absurd. And we have also some special patients. So some of those biological aging clocks sometimes help us to catch something that might not be very immediately recognizable in patients. So this patient is a normal 30 years old female who struggles to get pregnant, and she came and we measured the biological aging clock, and the delta was +2, which for this clock and this patient is a lot. And we repeated that with other aging clocks, and it turned out that indeed there was something making her biologically older, and those were not the parameters from the blood tests. And then it turned out that she had an autoimmune disease, quite a severe one. So sometimes we see things that might not be very approachable at the beginning. And those patients, here's another patient that actually then got pregnant. So we have a lot of patients coming actually just really to optimize their health or to answer some questions that we might not know about. I will skip a few things in order to give more time to actually other speakers, but just a quick mention of how we try to bridge the longevity medicine and the sick care, being between the patient's bed, the ICU, and actually the other types of data that we mine in AI and longevity field. And as Eric mentioned, we had recently this article that pinpointed that life events, infections, even pregnancy are changing the biological age. Actually, a lot of women reached out after that because they were afraid. So it's, again, very important to explain to patients what it means, biological age change, and how it is reversed. And there was a study also that we conducted during the COVID time in New York on 5,000 plus patients at the ER, where we have seen the change in biological age, but we also were able to see that the outcome, the prognosis for those who were biologically aged when they entered the clinic was worse. And on top of that, also those who didn't have a reversal within the first 2-3 weeks in their biological age, they also had a higher lethality and mortality. Similar insights were seen in a large cohort of cardiology data. This is a picture from the big paper from China of the biomarker consortium, where they were trying to illustrate how organ-based clocks are being developed. And these are data from 50,000 plus patients from Italy, the largest cohort of the chronic failure cardiac patients. And as you can see here, also we have seen that the biological age of those who had poorer outcomes was higher at the beginning, so it might be a good surrogate for prognosis, but also we were seeing that some of the markers from the functional testing or from the imaging, so echocardiography and other parameters, like left ventricular hypertrophy, for example, in the thickness of the muscle, was correlated to the biological age. So a good validation, or at least a good insight and motivation to prove that in further cohorts. The same in oncology. So here the biggest problem is we don't know how to treat older patients because they are mostly excluded from clinical trials. 65 plus patients, they are mostly not even included. If so, now there is a movement to include them. It's still a very low percentage. And this type of, this oncology insights. This data is coming from Switzerland, where we are already measuring the biological age in all patients who are coming into the clinic up front, but this is from retrospective study where we have seen a very good correlation of biological age and poor prognosis along all solid tumor diagnosis. It's not including the blood tumors. Hematologic cancers behave a little bit differently. And here is once again the validation also that it's different in females and males. As you can see here, the males have stronger correlation towards having poorer outcomes if they have a higher biological age at the beginning of their oncological journey. And I will discuss this tomorrow in a more detail, but just for us MDs to know, it's actually being already implemented. There are longevity medicine protocols in terms of diagnostics in prospective cohorts in sick care oncological wards. Last word about the brain. It's important also to measure the brain age, and we have heard about the biomarkers that are now coming from, for example, old retrospective longitudinal data like in Hallmask. NLP plays a very important role, but we also have some biomarkers from the blood that are being correlated with the brain age. Here a study from Chicago. And we have, for example, the brain age measurement that is based on larger cohorts of MRIs, functional MRIs and single MRIs to measure different parts of the brain. And again, this is coming as a kind of a clock. And it's very interesting because it also showed correlation to a faster cognitive decline and also reduced work attention, and other studies have been published. But interestingly, it's also very much based on the volumetric analysis and lesion analysis. So following those type of data is also very valuable. Last but not least, just to reiterate, longevity physician education is very important. We've published that paper in Lancet Healthy Longevity a while ago, talking about the importance, and we've developed the Longevity Education Hub, where physicians can get at least an introduction to longevity medicine and then also take an advanced course. It's still the only curriculum that is CME accredited by the ACCME. And we have different national chapters, so it's available in Chinese, in Spanish, in Portuguese, in Indonesian, and more languages are about to come. And we have 6,000 plus students all over the world, spread all over the globe. And with this, I would like to close, thanking you so much for being a part of the longevity ecosystem and being here with us.